All right, so welcome back, everybody, to the longitudinal lecture series that we have as part of the Brooklyn Initiative to Develop Geriatrics Education. So this is different than some of the student lecture series that you may be a part of, in which there's a recurring set of lectures that are given to students on rotations. This is a series of talks that's given over an entire year. And this is sort of the beginning of those talks, right? July is the beginning of the academic year. And this is a good time to start talking about, I think, a topic that is very important to making sure that you as clinicians, we as providers, are understanding the normal changes of aging and making sure that we are increasing our acumen in differentiating between normal and abnormal. So there's a whole lot of room for error in that process, and a whole lot that can go wrong when we as clinicians either underestimate what is normal aging or overestimate what is normal aging and is actually pathology. So it's really important that we talk about that. And there's quite a few slides today that I'll go into on that. So it's good to have you all back. And I look forward to giving this talk. Please ask questions. As always, either in the chat or as you join, we'll give you the ability to unmute your mic. At the end of the talk, you're going to have a link in the chat to give feedback about how I did. Please give me feedback so that I can get better. I'm trying out a new, or I guess it's not that new at this point, that newer way of my head appearing on the slides as compared to the standard way. If that's sort of jarring, that's a good thing to give feedback. And I won't do it again. And away we go. Happy Monday, by the way. Hope you're all are doing good. You had a good weekend. Recovered from the 4th of July holiday and are gearing up and into the new academic year. Very exciting. Good stuff. All right. So we're going to be going over the normal physical and physiologic changes of aging, talking a bit about normal development, describing the differences between normal and pathologic aging and how they interact, and talking about at least 3 pathways to healthy aging, although I'm sure there's more. No conflicts of interest. We are funded by HRSA and are very grateful for that funding, along with our funding from the New York State Department of Health. And all of our talks are framed around the Age-Friendly Health Systems Initiative and the 4Ms model of care. Making sure that we always understand what matters to our older neighbors that we're treating in clinic, taking a look at their medication, making sure that what we're using is judicious and not interacting with what matters to the older adult, not impacting their mentation or their mobility, and making sure we assess their mentation, which includes the 3 Ds of the 4Ms, dementia, depression, and delirium, and also making sure that we assess and adequately respond to mobility limitations in older adults. Really, really obvious model of care with some very low-hanging clinical fruit, but if you do it correctly, it pays off in real clinical dividends very, very quickly. Thank you, Dr. Taylor. Thank you. Thanks that you like seeing my head. I'm going to go by the acronyms. So before we go any further, although I realize that there's less trainees on here than I would expect, let's start by framing how old is old. And I'm gonna launch a quick poll to see what everyone in the audience thinks is old. I suspect that our faculty is going to give a different answer. Oh wait, let me make it sure so that our faculty can do the poll. Hold on. Relaunch polling. Allow panelists to vote. There, that should be better. Yeah.
And we're only allowed one answer.
Yeah, I'm sorry.
I'm joking. Dr. Reinhardt, I really do like that your head is on the slide. I think that this is a better format.
I think it's okay. It lets you to sort of, allows you to sort of, when you need to, take a break, and I can become very big. Right?
Oh, wow, brilliant. Okay.
And I can interact with everybody.
And so you can move to, okay, great. So you can move to different sides of the screen. No, that's really helpful because some of the formats.
Can you guys see me moving?
I can.
Yes, I can.
Sort of jarring.
But that's really good because some of our formatting has spaces in different places. So it allows us to kind of work with our slide format. It's good, all good.
Although I learned one thing, that the videos don't work. So I'm gonna have to reshare once we get to the videos. So it looks like almost everybody thinks that either in our 90s or old is a state of being, not a number. And I would encourage you to think that way, right? I would encourage you to think that way. That age is a matter of our experiences and our intent and how we, I didn't hit share, or did I? There
yes, no, we can see it.
Oh, good. And not necessarily the number, right? That chronologic aging doesn't always match with biologic aging, and vice versa, and that how we perceive ourselves and our age is remarkably different often from the number that is attached to us. I don't feel terribly different than I did when I was 21 or 18, and I hope that never changes. I'm sure my colleagues would agree. So I'm not sure that this one is going to work out as well since we have limited trainees. But before we do get started, maybe we could take 1 minute instead of 3 and just free associate in the chat on what you think of when we say normal aging. What comprises normal aging? What is there to expect? And don't edit yourself, although please don't curse, I guess, in our chat. You might include things about the social aspects of aging or the physiologic aspects of aging. Whatever comes to mind. So I see being healthy and aging in place. Not only being free of illness, but holistic health. Being old sometimes is a legal and program issue, qualifying for various things like Medicare, retirement, pensions, discounts, driver's license, limitations, etc. I agree. The bureaucracy of aging is definitely something we should have a talk on. Right? It's remarkable how many programs we could qualify for, but are sort of difficult to get into. Physiologic and psychosocial changes that have been found among most older adults across the upper levels of the lifespan. And there's lots of variability. Any of our students, we have Omotunde, Michelle, Emily, Dongfang, Justin. I'll let you maybe keep typing and I'll keep talking for a couple minutes. And we can come back to that idea. So I used to do this, and I will go back to doing so once we're back in person. I used to do this as a live word cloud sort of exercise where we would do a word cloud before the talk and a word cloud after the talk, where people talked about what is normal aging before and after we talked about it. And so this is an example of what the word cloud looked like after the talk. Talking about support and health and nutrition, family, legacy, exercise, grandchildren, progression, friends, wisdom. I'm always surprised that wisdom wasn't bigger. Whereas the word cloud before the talk used to be much more negative. I've noticed that students are more positive these days, which means maybe we're making a dent. There used to be more about loss, atrophy. Somehow a lot of the medical students would put apoptosis as an answer, cell death, which is a part of aging. That's true. But there's a big spread of what is normal aging, and how we conceive of aging impacts not only how we talk to our patients, but how we think about ourselves. And it is imperative that we become aware of our implicit biases when we are treating older adults, that we stop ageism at the door, that we leave it outside of the clinic room and hopefully outside of our lives in general, and become aware of what is normal and what is abnormal so that we can treat people as objectively and in as person-centered way. I'm getting a request to turn up my volume, and is that true for everybody? Am I soft?
No.
Okay.
I'll speak louder. Is that better?
I can hear you. Fine.
I'm not great at projecting. I should have joined drama when I was younger. So I'll do my best. Okay. And I'm going to have to reshare my screen, but I love this video, starting to look at what is old. This is from the AARP. Do you guys have my normal PowerPoint now?
Yes.
Yes.
Hey, how's it going? You can stand right there. That's your mark. How you doing?
I'm great. How are you?
Great.
Awesome.
Just tell us your first name and your age.
My real age?
My name is Paolo. I'm 25 years old.
My name is Daniela, and I'm 19.
24. 35.
31. 33.
I'm 26 years old.
What age do you consider to be old?
Late 40s?
Maybe 50.
I feel like 30 is a new 20, so I'd say like 40 is old.
I'd probably say 50s.
I'd like you to show me how an old person would cross the street. Show me how an old person would send a text message. How might an old person do a push-up? What about jumping jacks? Okay, hang on. There's someone I want you to meet.
Hello, I'm Birch. I'm 66.
Hi, I'm Daphne, and I'm 68.
I'm Dee, and I'm 55.
George Fassbinder, 75.
My name is Parvati. I'm 70.
Nice to meet you.
Nice to meet you.
We're gonna give you about 2 minutes to teach each other something that you are good at.
I can teach you a jump that I do.
Okay, please.
Both of your legs go up, and your arm goes up, and your left arm goes like
to yourself. Ready?
Okay.
1, 2, 3. Lift 1, 2, 3. And bring it to your heart. And bring it to your heart. Add the head in. Yeah.
You want to try to get your balance and raise up. Now you can bring your legs and your feet up. It's hard, right?
Yeah.
1, 2, 3, 5, 6, 7. So when you come out of a turn, either way, you go back to that basics.
Over. Now forward. Over. Yeah.
Square it like this, and give me a hook. Hook. Jab, cross, hook, and then we'll go like this, all right?
1, 2, 3.
Now, what age might you consider to be old?
Probably 80 or 90. He could just do everything that I told him to do. An age that I would consider to be old now might be 100.
Do you remember what you said?
Yeah, I said in the 50s, I thought that would be old. But when I thought about it, like...
Wait a minute.
I'm sorry.
I can do it. It really changed my thinking of what old is. You've taught me something today. Clearly, there's no way she's old, you know?
Now I know from today, hey, I don't look at age.
At my age, I feel like I did when I was in my 20s.
There's so many things that I still want to do. There's so many things that I can do. As long as I'm growing and learning, then age doesn't matter.
When people start stopping, that's when they start getting old.
Thank you. Thank you so much.
Thank you.
Okay. Thanks, Daphne.
It was great meeting you.
How long have you been doing this? Is this a new skill?
40 years.
Wow.
So much of aging is how we live our lives and how we think about it and how we perceive others, right? You could see how much impact the idea of what was old had on some of those individuals, right? When they heard what their younger counterparts said. It's important that we learn to think about how we perceive aging and how we talk about aging and where our implicit biases are. I'm just going to stay on this mode rather than switch back to avoid the disruption. So we're going to talk about Mr. Smith, 72-year-old African-American man from Grenada. Mr. and Mrs. Smith, both recently retired from their very busy careers as lawyers. He and his wife had planned to spend their retirement traveling and caring for their grandkids intermittently, volunteer regularly at City Harvest. They both exercise 4 to 5 days per week. Socially, physically active, intellectually vibrant couple from the Caribbean. Lovely, lovely folks. Lots of lovely folks in our clinic. So we're gonna come back to Mr. Smith, but I want you to think about and keep him in mind. Think about how healthy he sounds, and think about as we progress through his case, maybe where the risk factors were that caused perhaps some changes to occur later on in the case, and also what that has meant to him and his family. So we'll talk a bit about aging and immortality. Are the Smiths aging normally now? Feel free to unmute and shout out. Healthy, happy aging. So I would say yes, right? I would say at present, and as part of the case, they are aging quite normally, which begs the question, what is normal aging? How do we age? How do we define aging? So there's, throughout mythology, throughout history, humanity has been fascinated with the concept of lifespan and immortality. There are immortality myths throughout recorded and pre-recorded history, ranging from Greek mythology to the Fountain of Youth. to the Hindu pool of youth, myths, even what I would call modern day myths that are somewhat exaggerated claims of extraordinarily long life in certain populations like the Bilkabamba and the Hunzakuts, which turned out to be more exaggerated claims of extraordinarily long life that were based on limited record keeping amongst those populations. So tremendous fascination, and I would argue, ageism, right? A desire to live longer, a sense that dying and aging were negative things to be avoided, and we should be pursuing immortality. And so this has gone, there are examples also within religion, like the legend of the legend of Methuselah and Lamech. By modern day standards, the oldest documented human was a French woman, Jeanne Calment, who died in 1997 at the age of 122. The maximum average lifespan currently is about 115 years. The absolute upper limit, although this is mostly statistical arguments and it doesn't exist as something most of us will have to consider, the absolute upper limit is about 125 years based on statistical modeling. So defining old age, I agree with everyone on this talk that it's much more complicated than a simple numeric designation. However, the government, as it is often wont to do, has given us a definition for what is old, or what defines being a senior. The US Census Bureau defines being old age as 65 years and older. And many groups in many countries set the same age point for becoming elderly. In our clinic, in our service here at Downstate, you might find that we would accept younger people with multiple medical comorbidities, multi-complexity, and cognitive problems that perhaps has advanced their biologic age past their chronologic age. And we take those cases on sort of a person-by-person basis. And so within older age, there are subgroups that have been defined, ranging from the young old, which is 65 to 74, to old, 75 to 84, the oldest old, and then centenarians and supercentenarians. And this is important epidemiologically to understand which segments of the population are growing, which segments of the population have risk or are the healthiest, and where to target, I think, public funding as needed if certain segments are growing faster than others. And we live in an aging world. The population curves are shifting, they're flipping. We have increasing populations of older adults, people 65 plus, both in the US and internationally. And those populations are expected to continue growing throughout the next several decades. Whereas the populations of the youngest young, those less than 5, globally are on the decline as compared to previous decades. And this slide exemplifies how this is happening internationally, and how often internationally this acceleration into increased populations of late life has picked up. The pace of aging, or people aren't aging faster, but the pace at which populations are aging has dramatically increased as we've entered into the 2000s, and many populations are transitioning from developing to developed countries. So that leaves these populations, like you could see in South Korea, China, Thailand, Brazil, who've had sort of dramatic aging slopes, right? They're dramatically transition, their populations are of a person 65 and over are doubling from 7 to 14% in the span of about 2 decades, as compared to the US, which has had several decades to handle this change. And so this presents public health, I wouldn't say crisis, but it presents a public health dilemma where those populations may or may not have the providers in place who are trained to handle the shift towards older adults utilizing healthcare resources. And I'm going to go past this. And so here you could see, this is a slide representing female life expectancy in developed populations, developed countries. And I like to show this slide not only because you could see how dramatically improved the female life expectancy has been since the 1840s, which is, you know, truly marvelous. But it also helps us differentiate the fact that in the United States, despite our overall improvement in female life expectancy, we are lagging behind many of our developed counterparts in female life expectancy. This slide is a little old now, but this data hasn't changed dramatically since it was published. So we have a lot of room to grow in the United States. We should not think of ourselves as ahead of the curve. We're actually not ahead of the curve by many population health metrics, particularly those of the elderly. We have a longer talk later in this academic year on the epidemiology of aging by Dr. Helsner. And so I will defer some of this conversation until she gives her talk, but just setting the frame. And one of the fastest growing segments of the population, right, are the oldest old, right? The 85 plus, the centenarians and the super centenarians, which are expected to expand dramatically as we move towards 2050. So we as providers have to realize that if we are not pediatricians, we're going to be geriatricians. And if we're going to be geriatricians, we have to be ready to handle what comes with being a geriatrician. We have to realize that the burden of chronic non-communicable diseases is going to increase. The multi-complexity of our patients is going to increase. And we need to be able to differentiate between normal and abnormal aging so that we provide person-centered care without over or under treating our older populations. And that requires that sort of a sweet spot. And that's why fellowships exist. That's why these talks exist, to help you realize where that sweet spot is, and that we could provide the best 4Ms modeled age-friendly, person-centered care that we can. And so here you could see that the burden of chronic non-communicable disease is increasing over these next decade, and that countries that are not already high income, that are middle and low income countries, are likely to experience the burden of this shift dramatically, very dramatically. Back to Mr. Smith. So Mr. Smith, you know, who had led a remarkably healthy life until this point, was dragged in by his wife with a history of gradual onset over about a 2-year period, uncharacteristic couch potato behavior. So my superstar patient, lawyer, active gardener, active volunteer, traveling grandpa extraordinaire, had slowly become someone that was very difficult to get off of the couch. And his wife was very, very worried about this. He'd had a loss of interest in his hobbies. He loved to watch cricket. He loved to refurbish old cars and gardening, as I mentioned. He's a cool guy. Forgetful now, losing objects in the home, trouble with naming, and spends most of his days on the couch. He had limited interaction with his wife, and this was, we asked, this was new. Not all spouses get on with each other late into their partnership, but this was new for them. And he became irritable. He was sort of a very happy man, but now he'd become very irritable, was napping intermittently during the day, poor sleep at night as a result of those sleep hygiene deficits. And he was less attentive, mumbling to himself at times, and had this slowed gait, but no tremors. So how on earth did we get here? How did we go from superstar grandpa to couch potato? And so now that we've had a few of these, I guess, slides, and we've started to talk a little bit about this, in terms of theory, how we think about aging, I want to ask how do you think aging should be defined via theoretical model? And it looks like I had never stopped sharing the polling. I'm sorry about that. Should aging be defined chronologically, biologically, psychologically, culturally, or all of the above and more?
All of the above.
So we'll see if everyone agrees in just a second. Thank you, Dr. Gu.
Okay.
Looks like most people have responded. So it looks like everyone thinks all of the above and more, and I love you guys. That's great. That's absolutely right. There are many models for defining aging, and any single model taken in isolation would be remarkably reductionist, right? We are neither number nor biology, nor psychology, nor culture all on our own. We're many different things. I couldn't agree more. I guess I can stop giving this talk now, right, everyone? We're all on the same page. So, but there are multiple aging theories, and it's beyond the scope of this talk to go into each of them in detail, but I'm going to give an outline that you can review later and if you'd like to pursue further reading. There are models that surround evolutionary models of aging, physiologic, biologic, psychosocial models of aging, but they all interact around a general understanding of homeostasis in the older adult and shifting homeostasis across various systems. And all of these models interact in a remarkably complex manner in each individual person. And so careful, comprehensive history and understanding of each model, understanding of normal and abnormal aging guides the clinical assessment and should guide your treatment. So theories of aging, evolutionary models include the mutation accumulations theory and the antagonistic pleiotropy theory. The first model, the accumulations theory, posits that aging is non-adaptive. It does not alter fitness for reproduction. So genes expressed in late life accumulate and are expressed as phenotypic aging because they don't alter fitness for reproduction, right? So aging happens separately from fitness for reproduction, so there is not selective pressure to remove those genes from the population during the reproductive phase of life. Versus the antagonistic pleiotropy theory that posits that aging is adaptive. It improves reproductive fitness, but the selected genes have antagonistic effects in early versus late life. So they are beneficial for aging early or for reproduction early in life, and may have effects on longevity and the aging phenotype as we move into our later years. There are psychosocial theories of aging, including the activity and life course theory, the continuity theory, the gerotranscendence theory, and Ericksonian stages of development, which have to do with the transition through life, the accumulation of coping mechanisms as we adapt to age-dependent changes and events in our life. The Ericksonian stage that we're most commonly dealing with in our population is that of wisdom, differentiating, helping our patients to differentiate ego integrity and satisfaction with aging and who they are as individuals versus despair, not having accomplished their life's goals, not having accomplished and become who they meant to be. And then there are physiologic theories of aging, right, which cross from theories surrounding DNA integrity and stability, right? A very common theory involves the telomere changes, right? The shortening of telomeres as we age, contributing to physiologic aging. But also the theory surrounding free radical damage to DNA, synthesis fidelity, energy metabolism, physiologic signaling, response to pathogens or injury, and changes to physiologic reserves. Many of these homeostatic mechanisms and associated age-related declines in those homeostatic mechanisms can contribute to the overall aging phenotype in each individual, dependent up in large part how they've lived their life, on their environmental exposures, on their occupation, on the culture and environment in which they exist, which may or may not expose them to various stressors, which contribute to enhancement or in decline related to any of these homeostatic mechanisms. And so there are expected changes in physiologic changes of aging, which cross all of the major organisms or organ systems. For example, the cardiovascular changes. We know that there are atrophy of muscle fibers. There is some degree of atherosclerosis expected with aging, changes to systolic blood pressure, changes to compliance of the left ventricle, declines in pacemaker cells and baroreceptors. All of this leads to an overall increase in blood pressure, increased risk of arrhythmias, increased risk of hypotension with positional changes, and decreased exercise tolerance. And I would say before I go too far into these normal physiologic changes of aging, it's important, really, really important to remember that though these normal changes may be happening in a patient that you are treating, and they should be identified and understood, it is equally as important to be mindful that understanding of these normal physiologic changes of aging can contribute to an ageist assessment of that patient as having decline. It is expected that that person will have these declines, whereas in reality, depending on how that person has lived their life, they may or may not have a greater penetrance of each of these physiologic changes. So you have to check yourself. You have to be careful. There are muscular changes that can be expected. There's an overall change and decline in muscle mass, a deterioration of joint cartilage, decreased bone mass and osteoblast activity, which leads to some declines in muscle strength and bone density, some loss of height. I was very, very sorry to learn that around the age of 34, we all start to shrink a little bit. We start to lose some height. I think the first year I gave this talk in the medical school, I was right around 34. And that was a little bit of a check for me. Joint pain and stiffness, increased risk of fracture, alterations in gait and posture. And of course, there's CNS changes, declines in the number of neurons, increase in size and number of the neuroglial cells, some mild age-related decline, atrophy of the brain, an increase in cranial dead space. And overall, this leads to an increased risk of neurologic problems, including stroke, Parkinsonism, slower conduction and processing, some modest declines in some parts of memory, alterations in gait. There may be some slowing of gait, some widening of the gait, decreases in gait length, an increased risk of hemorrhage. And there are changes in the skin, which are sometimes more apparent in the clinical setting. There's a loss of dermal and epidermal thickness, an atrophy of the sweat glands, decreased vascularity and collagen cross-linking, some elastin regression and loss of subcutaneous fat, decrease in melanocytes and decline in fibroblast proliferation, which overall leads to a thinning of skin and susceptibility to tearing, dryness, pruritus, decreased sweating and ability to regulate heat, increased wrinkling and laxity of the skin, loss of fatty pads that protect bone and result in pain when sitting for too long, an increased need to protect from the sun and increased need to heal from wounds, or an increased graying of the hair, right? We'll take a break from talking about normal physiologic changes to think a little bit about checking our ageism as we go to the door. What happened?
Dr. Reinhardt. This is awesome.
Dr. Taylor, you raised your hand.
Oh, no, I was looking for a reaction. I just wanted to say that that was a wonderful video because I used the one with women. And I think that for us to try to think about how pervasive our aging language is, and that it is, I think that that is a really clever video, and I really thank you for that.
Oh, thank the AARP. I couldn't agree more. Couldn't agree more. And I see Shirley's comment that some of these normal changes sound quite tough. And the clinical language that we use to describe changes of aging can be quite tough. And I guess that's why I'm trying to include positive videos that might help us to frame how we think and talk to older adults about how those changes are happening and how much is happening for each individual. Dr. Gerard, did you want to talk a little bit about what you meant?
Yeah, I just think, we talk about aging as though it only happens to old people, but you start aging from the time you're born. I hadn't thought about it quite that way. And, when you talked about these are normal changes of aging, there are normal things that happen to us, as you pointed out, at younger ages that we only sort of link to people being old. And I think, in other cultures, aging is looked at very differently. It's like you get better when you get older. You're wiser, you're the wise men or women of the tribe or the community. And we don't, it's very different in Western culture at large, but in particular in the United States, it really has been shown to be quite different. So, and it's funny because I have conversations with friends about, these are normal things, but we're as bad as we get older. We're as bad as the providers who are ageist in talking about our own selves. Oh, well, it's a bitch to get old. So to treat those changes as though they're just part of life, is I think would be something for us all to think about.
I think that's right. And I think it's very important. It's very important in our clinic when people come in with, I think exactly as you've just framed it, right? They're having complaints that are essentially, that could be described as getting old as a, I guess I don't want to include a gender biased phrase, but getting old is tough, right? There's complaints about osteoarthritis. There's complaints about changes to gait. There are multiple changes to talking about changes to bowel habits, many of which would be ascribed to what is normal aging, and to talk with that person from a strengths-based focused, right? How many things are going well for you? Let's look at this. You're an educated individual that worked your whole life. You have a pension. You have good, strong social connections. You're able to do things that you wanted to do in retirement. And let's talk about how we can make sure that you are living out your goals, right? That in a way that doesn't involve me giving you medications for those things, because the medications aren't going to help anyway, right? It's really important. And while there is some negativity to the language, I do think it's important to know what can happen as we age to be able to frame appropriately. So I apologize for the negative clinical vernacular. I'm a little bit stuck with it. It doesn't mean we can't work together to make it better, though. Right? I think this is a repeat. And pulmonary changes, right? There's some changes to lung tissue elasticity and cilial atrophy, decreased respiratory muscle strength, along with some declines in musculoskeletal strength, as we talked about before. And all this leads to some declines in efficiency of ventilatory exchange and an increased risk and susceptibility to infection, atelectasis. We saw this in particular this past 18 months or so, heartbreakingly. And there can be an increased risk of aspiration and a decreased ventilatory response to hypoxia and hypercapnia. And of course, corresponding increased sensitivity to narcotics, which could affect pulmonary function. And vision changes and hearing changes, as we heard about last from 2 to 3 with Dr. Wygant. Changes to rod and cone function, pigment accumulation, decreased speed of eye movements, and changes to intraocular pressure, ciliary muscle atrophy, and lens changes, decreased tear secretion, which overall leads to some changes to visual acuity, visual field changes, and adaptation to night as it becomes darker during the day. Increased sensitivity to glare and incidence of glaucoma, increased eye dryness and irritation. And since we just had a whole talk on this, I'm going to go by this slide on hearing changes. But there's, of course, age-dependent changes on hearing, which, as Dr. Wygant pointed out, it's very unlikely that we should consider those as normal because we have very clear and effective treatments for those changes that impact quality of life quite dramatically. And there's GI changes, which span changes to liver size, salivary gland function, bowel muscle tone, taste bud atrophy, esophageal emptying, decreased acid secretion, mucosal atrophy. All of this leads to some decrease in appetite. Slowed passage of food, changes to absorption of calcium and iron, and alterations of drug effectiveness based on changes to acid secretion and absorption rate, an increased risk of constipation and associated illnesses. And I guess, again, important to note that where I'm talking about increased risk doesn't necessarily mean that that risk will penetrate to each individual, but that it is possible for an older adult to develop some of those changes. And of course, renal changes, changes to renal mass, loss of glomeruli, decline in functioning nephrons and small vessel walls, decreased bladder muscle tone, all of which leads to an overall decline in GFR, sodium conserving ability and creatinine clearance, and some mild increase in BUN. Decreased renal blood flow and alteration of drug clearance. Meds are much more likely to stick around longer. And while polypharmacy is a problem for a person of any age, for an older adult that has experienced some declines in GI and urinary renal function, polypharmacy is a particular risk because those meds are going to stick around longer and be able to interact with each other for longer periods of time and cause more problems, including fall risk. Endocrine changes, declines in hormone production, decreases in thermoregulatory capacity and febrile response, increased nodularity and fibrosis of the thyroid, and changes to basal metabolic rate. All of this leads to decreased ability to tolerate stressors, such as surgery, decreased sweating and shivering, lower baseline temperature. So we may not always be able to detect infection through elevation in temperature. Changes to insulin response and glucose tolerance, which is particularly important when we are experiencing stressors that require a heightened response. Weight gain, increased incidence of thyroid disease, and immune changes, which lead to an overall decline in immune function and decreased response to pathogens, decreased capacity for B cell growth and maturation. And some changes to cognition, although this is remarkably overstated in the popular conception of what happens to older adults as they age cognitively, right? There is some changes in free recall, source memory, and prospective memory. But overall, many forms of cognition remain remarkably stable. Recognition memory, temporal order memory, procedural memory, crystallized knowledge. All of these things don't change, long-term memory, crystallized knowledge. And older adults, through that collection of crystallized knowledge, have remarkable wisdom that should be shared with all generations. And we have to respect that and recognize that some of the slowing of processing that may occur with aging is dramatically outweighed by the gains in wisdom that occur as we live our lives. And there are changes of sleep, increased awakenings and arousal, decreased REM sleep, decreased slow wave sleep, and increased stage shifts. There are fewer cycles of sleep and some reduction in sleep efficiency. And this is important to talk to older adults about because it's probably not, with the current state of modern medicine, it's probably not that as we cross into our 70s and 80s that we should expect that our sleep efficiency is the same as when we were 20. And we shouldn't chase that previous efficiency through use of medications, which are likely to harm us. It is better to use sleep hygiene techniques, exercise, and other techniques to improve our sleep efficiency than to use medications. Let's turn back to Mr. Smith for a few minutes. So medical history-wise, fairly common panel of medical complaints in our population, and for folks at his age, some changes to vision, glaucoma, hypertension, enlarged prostate, and some coronary artery disease. Unfortunately, no hospital stays. No previous depression as far as past psych history goes, no psychosis, no mania, no hospital stays, no self-harm, but was a smoker, 1 pack a day for 50 years. And his wife was also exposed to secondhand smoke, I'm sorry to say. And this is where I think a lot of his vascular risk came from, which may have contributed to what we're talking about in regard to his change in function. No other drugs, no alcohol use, no hospital stays. Very minor surgical history, had appendectomy back in the 80s. And a sort of mild medication profile, tamsulosin, hydrochlorothiazide, timolol eye drops, and some sort of uncertain prostate supplement and nerve tonic that he gets from his naturalist. I've never got a full list of what was in these 2 supplements, although I suspect that they were interacting with some of the medications. It's hard for me to know. Oops. So though he yearned to be a hot potato, he was in fact a sad potato. Any straightforward explanations? Is this normal aging? The decline to living on the couch, irritably not engaging in his hobbies, interests, and activities? I would say no. So how did we go from a healthy, active lawyer to Mr. Potato? And so this is one possible, I'm going to, I guess, just posit an explanatory model that has us moving along the axis of time with pre-existing physiologic reserves across our organ systems that are combined with genetic predisposition, our life's environment and occupational and other exposures, our biologic and psychological coping mechanisms, our behavioral coping mechanisms rather. And all of these predispositions and reserves interact with the axis of time and ongoing stressors to cause a gradual loss of physiologic reserve. These interact with age-related and other chronic and acute diseases to further diminish our capacity to respond to stressors. And as stressors accumulate and further reduce our homeostatic capacity, our physiologic reserves, we move further and further away from our ability to restore homeostasis and move closer and closer to a state of pathology. And so perhaps Mr. Smith's aging was accelerated by his smoking use. Not perhaps, most likely. And other perhaps environmental exposures that we don't know, and polygenic risk, which I'm not able to currently fully classify or fully understand in the current clinical milieu. Dr. Taylor. see your hands up.
Yes, I have a question about attenuation and acceleration. I was just wondering if you could distinguish those two in terms of aging acceleration and aging attenuation.
Can you
Maybe
expand
this
on
is-
that a little bit? Yeah.
Oh, this might be a question that is actually a little bit specific to the HIV realm. So there's been a huge debate in terms of older adults aging with HIV, and if their aging is being accelerated or if it's attenuated. And so I was just wondering with this particular model, and I'm not exactly sure if I really buy the, aging is being attenuated as opposed to being accelerated with HIV. And I was just wondering that's an example.
I suppose this is an acceleration model, if that's what, yeah.
And
I think this is a good question. Yeah. I think let me think about it, and I'll come back with a better answer in a little bit.
Thank you.
Well, thank you always for good questions. I think there's ways to improve this talk, so I appreciate that question. I think there's some additional pieces that should be added. So one example of the this paradigm would be thermoregulatory capacity, right? In which we move from a state of baseline function, and we have age-related physiologic changes, right? Skin changes, decreased number of blood vessels, changes to muscle mass, decreased nervous system response, so multi-system physiologic changes that have occurred across the axis of time, which lead to an overall decline in or change in thermoregulatory capacity. And then you add stress, you add temperature change, for instance, you add this whole heat wave on the West Coast in which you put people into a heat dome. And their diminished thermoregulatory capacity, if they don't have coexisting pathology, stroke, mental illness, et cetera, would still leave them at risk for hyperthermia. And if you have increasing comorbidities, that would place them at increased risk for declines in thermoregulatory ability, medications included too. There is even higher risk of hyperthermia. And so on. And so if there's then a hypothermia event that leads to further loss of physiologic reserve, that person then moves further along the path towards pathology, or as happened out in the West Coast, many people passed away. There's been well over 100 deaths at this point linked to hyperthermia on the West Coast. Somebody who's able to Google can give us the current estimate. And so the geriatric syndromes are an example of the complex interactions between normal age-related processes and stressors, right, that further move us, disrupt homeostatic mechanisms. And this is the list of geriatric syndromes. We have talks on most of these as the year goes by. And frailty is a prime example in which there's multi-system decline, multiple organ systems in geriatric syndromes contribute to an overall loss of weight, strength, change to walking speed, and declines in physical activity. And frailty then puts that individual at increased risk of falls, disability, and mortality. So unfortunately, on exam, Mr. Smith was found to have moderate memory deficits. Short-term memory, visuospatial function, executive function with a mini mental of 17 out of 30, which is moderate decline. And his neuropsychiatric inventory was positive for depression. He was markedly depressed, apathy, insomnia, hallucinations, and irritability. He met 7 out of 9 DSM-5 criteria for depression. And his exam was fairly unremarkable, except for some mild systolic, some mild hypertension and elevated cholesterol. So we treated him for depression, possible pseudo dementia with meds, sertraline. We tried to use behavioral activation strategies. Unfortunately, he did show some initial improvements in mood and cognitive function, but he never completely remitted. We sent him for neuroimaging because his cognitive status was worsening. So now we've talked about all of these negative things about how we can age well, or how we might experience the physiologic changes of aging. And we have to think a little bit how to age well. And there's some very sort of low-hanging fruit is that we should all be engaged in right now to make sure that we are aging as healthfully as we can, maintaining a healthy diet and weight, including the Mediterranean diet or the MIND diet, which is a combination of Mediterranean and DASH diets. Some people have studied and found positive benefit to various caloric restriction paradigms. People really have a hard time tolerating caloric restriction, so people don't maintain it long enough to obtain the benefits of that model. But periodic fasting is much easier to maintain, including alternate day fasting is probably also safer and still has aging benefits. Intermittent fasting is a newer model that also seems to have some benefits. And of course, limiting toxic exposures, get preventive care, exercise regularly. Doesn't necessarily extend lifespan, but it dramatically improves quality of life. Regular social and cognitive activities. And there are some pharmacologic interventions that are being studied, but there's really uncertain and limited benefits in humans. I bring these up not because necessarily they are effective, but because there are patients in the US and internationally that are already using these things sort of illicitly. They're obtaining prescriptions for compounds that may provide anti-aging benefit and using them, and they don't always tell their doctors about them. And it's important that you might understand that this is happening and ask your patients about it. I'm going to leave hormesis alone because that's sort of of limited evidence in humans. So we sent Mr. Smith for neuroimaging. He had global atrophy, ventriculomegaly, chronic white matter ischemic changes. We talked about doing a further confirmatory testing regarding his diagnosis so that we could give them the most accurate diagnosis possible. The family declined. So he left this appointment with a clinical diagnosis of probable Alzheimer's disease, unfortunately, versus mixed due to multiple etiologies. And we started donepezil, and eventually we started memantine. We got him engaged in as much advanced care planning as we could, estate planning, advanced directives, and we set him up with a day program, and his wife went to a caregiver support group. We're over time, so I'm going to skip the last video.